My passion is at the intersection of hospital epidemiology, vascular access, and patient safety. I've been fortunate throughout my career to create a program that allows me to explore the impact on our patients and strive to see those focuses align. I have studied, published, presented, and mentored to ensure every patient who entrusts us with their care has all of their invasive vascular access devices treated with the respect they deserve, knowing that any line can truly be our patient's lifeline. One of my biggest abilities to impact is through encouraging and teaching others about data collection and using it to tell the stories that allow us to advocate for improved practices to drive the best possible outcomes for our patients. I wish I wasn't still having to say something about peripheral IVs here, but I truly think that's still my answer. The fact that Helm just reissued Accepted but Unacceptable and told us that basically we're not doing any better than last time he looked really helps emphasize that. With our laser focus on central line associated bloodstream infections and other associated complication, I think we've done ourselves a disservice to understanding the full impact of our other vascular access device choices. But if we collect robust outcomes data across the entire variety of devices available, and we gain a better understanding of how each performs in our institution, with our insertion team and our staff doing care and maintenance, we can use that to help predict which devices are most likely to get us the desired outcomes. Having that level of understanding makes it so much easier to truly do a risk assessment that's based on an understanding of our risks and opportunities instead of just acting on emotions in the last encounter or the last question that's been raised. Getting back to peripheral IVs, we know they represent the most commonly used invasive device in our hospitals, so it's mind-boggling to me that we're still at the point of practically begging people to consider the risks and risk reduction strategies, even if it's just point prevalence or periodic surveillance. 2019 had an exciting start because we're starting to see some alignment and recommendations. ECRI, one of our most respected patient safety organizations, actually included peripheral IV bloodstream infections as one of the top 10 patient safety concerns for this year. This is huge. When our executive teams come to us and ask us what we're doing about it or how we're addressing it, we should be armed with data. Need help? Call me. Around the same time, CDC put out a call for comments, and it's pretty much what I've been dreaming of since I started in infection control around 25 years ago. They are considering expanded surveillance to move beyond just CLABSIs and to include all hospital onset bloodstream infections. The final decision on whether or not that's going to go through has not yet been announced, but by working with our vascular access colleagues, we were able to get a lot of feedback to CDC on how the current surveillance protocols focusing only on central lines may have created unintended consequences of minimizing the risk or potential concerns with other vascular access devices. I'm hopeful the protocol changes go through, but even if they don't, we've raised a tremendous amount of awareness. For me, data is where it all starts, and I've been able to leverage meaningful changes for patient safety as well as staff considerations, such as nursing time. I've been with my current hospital for 17 years now. Wow. And we've collected bloodstream infection data for all those devices since I joined the organization. And we frequently audited performance across all devices throughout my tenure, even going beyond infection. Over the past several years, we've really expanded and formalized that process. With the support of our executive team, our process measures are audited and aggregated on a monthly basis. Nursing unit scorecards now include not only their CLABSI rate, but their hand hygiene numbers, their central line utilization, and their dressing integrity numbers. It's our hope that by focusing on some of these precursor to infection or complication, like how many strikes before you're out, we can continue to emphasize preventing infections rather than just responding after they occur. We audited our practice and our outcomes several years back and identified dressing disruption and frequent dressing changes were precursor to around a quarter of the infections we were seeing. with the guidelines and standards all aligning on the importance of dressing and the literature supporting that frequent dressing changes for disruption can have a huge impact on bloodstream infection rates, this was a priority for us. It started as a project on just peripheral IVs, but at the insistence of our frontline staff, quickly became standardized throughout all of our vascular access devices in our inpatient care setting. After reviewing our outcomes and opportunities and trialing a variety of products, we standardized to adding mastosol to our vascular access dressings. We have seen our fully intact dressings skyrocket from 55% to consistently above 95%. We work closely with our professional development team and our wound and ostomy nurses to make sure we're also looking at any considerations about skin issues or skin injuries. Detachol and other adhesive removers are used consistently with our adhesive dressings, with almost zero complications noted after literally tens of thousands of applications on our patient population since inception. We have a jamboree every month that serves as our internal validation. And even with our strictest observations that go way beyond just adherent dressings, we're consistently above our goal of 80% across all devices. By decreasing our need for unscheduled dressing changes, we're saving our most valuable commodity, which is nursing time, as well as saving on supply costs, decreasing the risk of infection. Plus, we are not seeming to contribute anything to risk of increased skin complications. That's what I call an all-around win.